Welcome to Board Pearls. This is episode 3 of the Barrett esophagus and esophageal cancer chapter in the esophageal disorders module. This episode is esophageal cancer, the 2 histologies, how it's staged, the 1 depth boundary that decides endoscopic versus surgical treatment, and the regimens for locally advanced disease. It picks up right where eradication ended, with the patient whose resected lesion turns out to have invaded past the mucosa, or who shows up with a cancer outside any known Barrett's. The first thing to sort is which of 2 cancers you're dealing with, because they share the tube but live different lives. Adenocarcinoma is the common one in the U.S. and has risen sharply over recent decades. It sits in the lower third and at the junction with the stomach, and it's driven by reflux, central obesity, smoking, and Barrett's. Squamous cell carcinoma is the dominant type worldwide, sits in the mid-chest portion of the esophagus, and is driven by tobacco, alcohol, very hot drinks, achalasia, old lye strictures, and a few genetic and inflammatory conditions. Sorting the histology first is worth the habit because it predicts the risk factors, the location, and the treatment. A mid-esophageal tumor in a heavy smoker with achalasia is squamous until a biopsy says otherwise. A lower esophageal tumor in a man with chronic reflux and central obesity is adenocarcinoma. A few risk associations are worth recognizing by name. Tylosis is an inherited thickening of the palms and soles, and despite being a skin condition, it carries a very high lifetime risk of esophageal squamous cancer, so those patients get surveilled. A lye ingestion produces squamous cancer decades later at the site of the chronic stricture, so surveillance starting a couple of decades after the injury is reasonable. Achalasia raises squamous risk too, but not enough to justify routine surveillance. And very hot beverages are a recognized cause of squamous cancer. So hot tea paired with a mid-esophageal mass and a vignette is a link you should already know. Staging is what chooses the treatment, and the depth categories are the part to hold cold. The earliest, high-grade dysplasia is carcinoma in situ in concept. Then invasion deepens in steps. Into the mucosa, then across into the submucosa, then into the main muscle wall, then into the outer coat, and finally into neighboring structures. That last one splits by resectability, structures a surgeon can take along with the specimen, like the pleura, pericardium, or diaphragm, versus ones they can't, like the aorta, the spine, or the airway. Nodes are staged by how many are involved, 1 or 2, 3 to 6, or 7 or more, and then the presence of distant spread. The single most important line in this whole disease is between a cancer that stays in the mucosa and one that reaches the submucosa, and the reason is lymph nodes. A cancer confined to the mucosa almost never is spread to nodes, so it stays an endoscopic problem, treated by resection and ablation. Once it crosses into the submucosa, the node risk climbs steeply with each deeper step, so it becomes a surgical problem for most patients. That jump at the boundary is why mucosal disease is handled endoscopically in essentially all cases, and submucosal disease crosses the line to surgery. There's one exception that gets rewarded. The favorable patient with only the most superficial submucosal invasion who can still be managed endoscopically, and the qualifiers are specific. The invasion has to be shallow, under 0.5 millimeter, the tumor well or moderately differentiated, with no invasion of lymphatics or nerves, and clean margins on an en-bloc resection, and the patient needs a real reason to avoid surgery, usually significant other illness. Even then there's a small node risk, which the patient and surgeon weigh against the genuine mortality and morbidity of an esophagectomy, so this is recognized as a reasonable option in that narrow group rather than a default. Deeper submucosal invasion belongs to surgery. For the rest, a tumor into the main muscle wall without nodes is generally surgical. With the role of pre-op therapy debated, so upfront surgery and pre-op chemoradiation then surgery are both reasonable. Locally advanced disease, meaning into the outer coat, into resectable neighboring structures, or any node-positive disease without distant spread, is treated with pre-op chemoradiation followed by surgery in adenocarcinoma and most resectable squamous cancer. And distant metastatic disease is palliative. The staging workup runs in a fixed order that makes sense mechanically. Endoscopy with biopsy establishes the diagnosis and the histology. Endoscopic resection of any visible early lesion is what actually gives you the depth for early disease, because forceps biopsies can't judge invasion. A CT of the chest and abdomen shows the gross local extent, the regional nodes, and obvious distant disease. A PET scan catches distant metastasis that would change everything in someone headed for curative treatment. And endoscopic ultrasound gives the most accurate local depth and node assessment with needle sampling of suspicious nodes. So the order is endoscopy, then CT, then PET, then endoscopic ultrasound, with resection whenever a visible lesion might be early enough to stage by depth. Esophagectomy is a major operation with real perioperative mortality and substantial morbidity. The complications including anastomotic leaks and strictures, chylothorax, arrhythmias, pneumonia, and long-term dumping, diarrhea, and reflux, and outcomes are clearly better at high-volume centers, so referral to one is part of the right answer. The transthoracic approach is favored for lower adenocarcinoma, with other approaches chosen by tumor location and surgeon preference. Two regimens carry locally advanced disease, and the way to hold them is by histology and timing. The first is the pre-op chemoradiation approach, carboplatin and paclitaxel given with concurrent radiation before surgery, which improves survival over surgery alone and works for both histologies, with the larger benefit in squamous cancer. That's the neoadjuvant standard for resectable locally advanced esophageal cancer of either type. The second is a perioperative chemotherapy regimen, a 4-drug combination given as several cycles before and several cycles after surgery, which is the standard for adenocarcinoma of the junction and stomach, improving survival over the older regimens. So the simple split. The chemoradiation regimen is the neoadjuvant option for both histologies, and the 4-drug perioperative chemotherapy is the alternative for junction and gastric adenocarcinoma when chemoradiation isn't chosen. There is an immunotherapy addition worth recognizing. A patient who still has residual cancer in the specimen after pre-op chemoradiation and surgery benefits from a year of adjuvant checkpoint inhibitor therapy, which roughly doubles the disease-free interval. So residual disease at resection after that neoadjuvant approach means a year of adjuvant immunotherapy. Definitive chemoradiation, without surgery, is the curative intent choice for squamous cancer patients who aren't surgical candidates, and it's actually preferred over surgery for cervical and very high esophageal squamous tumors, because operating there would require removing the larynx, and the functional cost isn't worth it when chemoradiation gives comparable cancer outcomes. So a squamous tumor sitting up above the thoracic inlet is not a chemoradiation then esophagectomy case, it's a definitive chemoradiation case. Palliation in metastatic disease is about controlling symptoms and systemic therapy. A self-expanding metal stent relieves obstructing dysphagia and is the main tool for that, with external radiation as an option when stenting fails. Systemic treatment is a platinum and fluoropyrimidine backbone, with a checkpoint inhibitor added for PD-L1 expressing tumors and trastuzumab for HER2 positive ones, which is exactly why HER2 and PD-L1 testing is standard at the diagnosis of metastatic junction adenocarcinoma, because that testing changes the regimen. Metastatic squamous cancer likewise gets the platinum fluoropyrimidine backbone plus a checkpoint inhibitor. A couple of adjacent points. Anastomotic stricture is common after esophagectomy and responds to dilation in most cases, and chronic reflux is expected because the operation removes the anti-reflux barrier, so lifelong acid suppression is standard. And scleroderma esophagus, with its absent peristalsis and weak sphincter, drives severe reflux and carries a meaningful Barrett's rate, though cancer in that group is actually rare. So the path the patient travels, from a visible nodule to an answer. The nodule is resected before the field is ablated, because the resection is the staging test. The depth on that specimen either keeps the patient endoscopic by confirming mucosal disease or the favorable superficial submucosal exception, or sends them to surgery by showing deeper submucosal invasion or node-positive locally advanced disease. The locally advanced patient gets pre-op chemoradiation or perioperative chemotherapy, depending on histology and location. Residual disease afterward earns a year of adjuvant immunotherapy, and metastatic disease gets palliation with biomarker-directed systemic therapy. And the staging always runs in the same order: endoscopy, CT, PET, endoscopic ultrasound, with resection as the depth test for any early visible lesion. The next chapter changes the lens completely. Eosinophilic esophagitis is an allergic disease of the esophagus, defined under the microscope by a threshold count of eosinophils treated with acid suppression, swallowed topical steroids, or dietary elimination. Alongside it sit the infectious esophagitis, where the organism is predicted by the patient's immune status and where in the wall it lives, which is what tells you where to biopsy. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 3 of Chapter 4, and I'll see you in the next one.